Hi guys. The whole group isn't here yet, right?
Not yet, Doctor.
Yeah, I'm on my phone, so how many altogether? 28 are there?
38.
28, right? Ready? 38.
Yes, Doctor.
So many? Okay. Anyway, I'll leave it for a while. Let's see whether my kids will crash the thing again. Who's presenting? Who's presenting? Patin. You guys say 38, right? 38 students, is it?
Yes.
Another 4 more. I think can just start now, I think. Aisha, wait, the other day I was teaching the 5th years, so there are a few videos on cardiovascular examination. Do you want them? If you want, then I'll just email the links to, I'll just WhatsApp the links to Aisha Malik. One, Anggo, the one.
One, doctor.
Okay. So I'll just WhatsApp them to Aisha lah. Just basically videos on cardiovascular examination. And then also a few, I think a few how to, and then there's a few where you can hear the murmurs. Okay?
Okay.
I think can just start lah. Not everybody's here, I think.
Okay, doctor.
Just start me lah.
Okay. Hello, can you hear me?
And
Yes.
Okay. Good afternoon, doctor. Today for our seminar presentation, the theme is immunology. Next slide. So these are our 5 topics under immunology theme. First of all, Kawasaki disease, which will be presented by me, scarlet fever and acute rheumatic fever, SLE, juvenile idiopathic arthritis, and HSP. So I'll be presenting Kawasaki disease. My name is Arisha. This is my outlines for today's presentation. Next slide. Okay. So Kawasaki disease is also known as Kawasaki syndrome. It is an acute febrile illness with prominent vasculitis, inflammation of the vessels which affect mainly medium-sized artery in children. And it is first described in Japan by Tomisaku Kawasaki in 1967. And it is one of the leading causes of acquired heart disease in children. This Kawasaki disease occurs worldwide, but it has highest prevalence in Asian population, in Japan, Taiwan, and Korea. And in USA, Kawasaki occurs in 100,000 children, 25 under 5 years of age. And in Malaysia, Kawasaki disease is most commonly occur in children aged 1 to 4 years old with peak incidence at age of 17 months. And male has slightly high ratio compared to female with 1.6 to 1. Next slide. So this is the pathophysiology of Kawasaki disease. The etiology is unknown. It probably because of the infectious agent, but up to now, there is not a single study that can identify the agent that can cause this disease. The thing is genetic susceptibility as this occurs in Asian population and environmental factor. So these factors causes inflammation of the medium-sized arteries, for example, coronary artery, renal artery, and this inflammation cause destruction of all 3 layers of the artery. And when there is inflammation, the inflammatory infiltrate will be replaced by fibroblasts and causes thickening and narrowing of blood vessels. And this will cause the blood flow obstruction, causing ischemia to respective organs of affected artery. So patient can be presented with acute kidney injury, limb ischemia resulting in gangrene, and intestinal ischemia causes perforation, and at last peritonitis. When this vasculitis causes destruction of all the layers in coronary artery, the vessels become weakened because it lost structural integrity and necrosis. So as a result, it can cause a coronary artery aneurysm, which will predispose to thrombus formation, and lastly, acute MI. Next slide. So these are the clinical manifestations of Kawasaki disease. First of all, the patient must have a fever of at least 5 days duration. Usually the fever is high. The patient also has bloodshot eyes without thick discharge, red, dry, cracked lips with extremely red and swollen tongue. We call it strawberry tongue. And patient also have extremity changes, which is the erythema and swelling of the palms and soles, sometimes presented with firm and painful induration. And by the 2 to 3 weeks after onset of fever, patient will have a peeling of the skin. Other than that, patient also have a rash described as macular papular rash, mainly on the trunk and genital area. Next slide. So Kawasaki disease is diagnosed with the presence of at least 5 days of fever, plus at least 4 of the following 5 criteria. The criteria are: first one, if bilateral bulbar conjunctival injection, the red eyes, polymorphous rash, especially on the trunk, swollen erythematous hand or feet, oral mucosal changes, which I mentioned just now, strawberry tongue, swollen cracked lips, and then cervical lymphadenopathy, which is at least 1.5 centimeter in diameter, and it is usually unilateral with mild or no overlying erythema. When the patient has fever and presented with at least 4 of these 5 criteria, we can diagnose the patient as having complete Kawasaki disease. But if the patient has fever but did not complete the criteria, we can call it incomplete Kawasaki disease. Next slide. So complete Kawasaki disease is a clinical diagnosis. It means that to diagnose complete Kawasaki, we do not need any laboratory markers. We simply diagnose based on the symptom and the physical examination. But when the patient did not meet the criteria for complete Kawasaki disease, we order certain lab tests and imaging. The first one is complete blood count. Most of the patient has normochromic normocytic anemia and thrombocytosis. And the ESR and CRP will be elevated because of the vasculitis. And patient also has a hypoalbuminemia. And based on the liver profile, some of the patient also presented with transaminitis. Echocardiography we ordered when we made the diagnosis of Kawasaki disease, because one of the complications of Kawasaki disease is coronary artery aneurysm. So as soon as we diagnose the patient as having Kawasaki disease, we have to do echo as soon as possible. And then, okay, that's for Kawasaki disease. But if 3 or more supplemental lab criteria are positive, I mean this CRP, ESR, CBC is positive, we can diagnose the patient as having incomplete Kawasaki disease. And we can also order ECG to detect any myocardial infarction as a complication of Kawasaki disease. Next slide. So for management of Kawasaki disease, the principles of therapy is to reduce inflammation in coronary arteries and minimize incidence and progression of coronary artery aneurysm. And long-term therapy in individuals who have developed coronary artery aneurysm is to prevent myocardial ischemia and infarction. For Kawasaki disease, we administer IV immunoglobulin 2 gram per kilogram as a single infusion over 12 hours. This IV immunoglobulin will reduce acute inflammation and reduce the rate of coronary artery aneurysm development. And this IV immunoglobulin is combined, we also give aspirin beside the IV immunoglobulin, which is given 30 to 50 milligram per kilogram per day in 4 divided dose for 2 weeks. And then we have to monitor the echo and ECG. And then we continue the aspirin for minimum of 6 weeks duration. So this is some of my references. Yes.
Okay, because it's such a long, so many topics at one go. I think after each topic, if you have any questions, just ask us. The aspirin you continue at least 6 weeks, but you must also check your inflammatory markers and also drop down back to normal. So your inflammatory markers will be your ESR and CRP. Any questions or not? What's the so many topics? No? Yes? No? Kalau tak ada, then continue.
No, Doctor.
Okay, then let's go on to the next one.
Okay, thank you, Aisha. So now it's come to my part. I will communicate a bit to everyone. So I will explain about the scarlet fever and also the rheumatic fever. Next. So basically, this is my outline for my parts. Next. Okay, first, what is scarlet fever? Next. Okay, by definition, it is an upper respiratory tract infection associated with characteristic rash, which is caused by infection with pathogenic azotoxin, producing group A Streptococcus disease in individuals who do not have antitoxin antibodies. Next, it is caused by a group A beta hemolytic Streptococcus, which specifically Streptococcus pyogenes. It is a gram-positive bacteria, a non-mortal, non-sporing cocci, and it is part of our skin microbiota, which is a part of human normal flora. Usually, the mode of transmission by the infected person is by respiratory droplets, and patients are contagious during the acute illness and subclinical phase. Next. That is epidemiology for the scarlet fever. Scarlet fever now accounted less common and less virulent than in the past. The infection rate increased in overcrowded situations, such as in school or in university. It predominantly occurs in the children aged from 5 to 15 years old, but also can occur in adults. By the time children reach 10 years old, 30% of them have developed lifelong protective antibody against streptococcal pyrogenic exotoxins. So it will prevent further disease manifestation. And also it is rare for children less than 1 year old to get the scarlet fever because due to the presence of maternal antitoxin antibodies and lack of prior sensitization. And males and females are affected equally. Next is the clinical manifestation of the scarlet fever. The incubation period is about 2 to 5 days based on the CDC. And patients usually will have sudden onset of fever, sore throat, headache, chills, myalgia and malaise, vomiting, abdominal pain, seizure, tachycardia, lymphadenopathy, which is tender. And also the patient also will develop rash about 1 to 2 days after the onset. Next. Okay, about the rash, it usually begins around the neck and will spread into the trunk and the extremities. It is characterized by diffuse, finely papular, and when there is erythematous eruption, it will become bright red discoloration on the skin. Okay, the eruption will cause in parts a dry, rough texture to the skin. So the skin will resemble the feel of coarse sandpaper. So we call it the sandpaper-like feel. And the rash also blanches on pressure. It is often accentuated in the creases of the elbows, axilla, and groins. Usually after 3 to 4 days, the rash begins to fade. It will followed by discommission, initially on the face. Occasionally, there will be sheet-like discommission around the free margin of the fingernails, palm, and soles. Next. Okay, next is about the pastille line, or we call it pastille signs. It is due to the capillary fragility increase and will cause rupture. As I mentioned before, usually the rash accentuated in the crease of the elbow, axilla, and groin. It is due to these pastille lines. It will persist about 1 to 2 days after resolution of the generalized rash. Next. Okay, the patient also will have erythematous cheeks, pallor around the mouth, and the mucous membrane will be bright red and scattered petechiae on the soft palate. Okay, the tongue, the first during the rash, it will heavily coated with the white membrane through which edematous red papillae protrude, give the appearance of white strawberry tongue. During the discommission, the white membrane will slough out, so it will show red strawberry tongue appearance. The tonsil also will be red, edematous, and will be exudative. Next. Okay, these are just a mnemonic for the scarlet fever. You can read it after this. Next. Okay, next is the complication of the scarlet fever. It can be divided into two, which is suppurative and also non-suppurative. Usually, the supuratives are result from local and hematogenous spread of the organism. The examples are peritoneal abscess, retropharyngeal abscess, cervical lymphadenitis, otitis media, and also pneumonia. For the non-suppurative causes, example will be acute glomerular nephritis and also rheumatic fever. This complication occurs after original infection resolved, thought to be the result of the immune response. Next. So for the investigation, diagnosis is mostly made by a clinical presentation. But however, we can also do some blood tests. For example, like full blood count. The expected result will be leukocytosis. We also can do some liver function tests, also renal profile, and also renal analysis. These tests are done to detect some changes associated with the scarlet fever complication, as I mentioned before. However, these tests also can be a part of routine medical checkup, routine examination, investigation. And for the diagnostic test, it will be the throat culture. It's the gold standard for the scarlet fever. And so we can also do the streptococcal antibody test, which is anti-streptolysine O titers. Next. Okay, comes to the principle of management for the scarlet fever. The goals in treatment of scarlet fever are to prevent acute rheumatic fever, to reduce the spread of the infection, to prevent the post-streptococcal glomerular nephritis and separatis squalae and to shorten the course of illness. And antibiotic therapy is the treatment of choice for scarlet fever. The first antibiotic, the first choice of antibiotic will be the penicillin. And if the patient is allergic to penicillin, macrolides will be the alternative, which is such as azithromycin. Okay, next we move into the next topic, which is the rheumatic fever. Okay, by definition, rheumatic fever is an inflammatory disease of the childhood resulting from the untreated Streptococcus pyogenes pharyngeal infection. It is due to the same organisms like scarlet fever before, which is group A beta hemolytic Streptococcus. There are some risk factors involved for rheumatic fever, which is such as low sanitation level, overcrowded living conditions, low economic and social status area. It is also can be due to untreated or incomplete treatment of streptococcal pharyngitis. Next. Okay, for the epidemiology, it is uncommon in developed country. Because what reason? Because in the developed country, there is improvement in sanitation level and also reduction in overcrowded living population. And also rheumatic fever also is the most important cause of the heart disease in children worldwide. Because rheumatic fever will progress to the chronic rheumatic heart disease, about 80% of the cases. Most common in children between the age of 5 to 15 years old. In Malaysia, the rheumatic fever and its causes are still common, but the exact incidents are not known as these diseases are not reportable and no study has so far been carried out to assess them. Next, we move into the pathogenesis. At the Streptococcus pyogenes, there is M protein, which is strongly immunogenic, so it can cause a molecular mimicry in our body. Next diagram. Next slide. So, several theories of pathogenesis have been proposed, notably cytotoxic theories and also immunology theories. I will explain a little bit about the cytotoxicity theory. It suggests that group A Streptococcus toxin or gas toxin involved in the acute rheumatic fever and rheumatic heart disease. Gas produce a number of enzymes that are cytotoxic for mammalian cardiac cells, such as streptolysin O. But a major problem in this theory is its inability to explain the substantial latent period between the first gas infection and also the onset of acute rheumatic fever. So that's why mostly it said that causes acute rheumatic fever is due to immunologic theory because it can explain the latent period between the first gas infection and the occurring of acute rheumatic fever. It is due to, as you can see in the diagram, due to molecular mimicry by the pathogens. So our antibodies will cross-react with the M protein because these M proteins share the same epitopes with the human myocardial protein such as myosin. So when this happens, our body antibody will attack this cell that which reside in the cardiac, our heart. So it will produce some clinical manifestations such as pancreatitis. And also for the Syndeham Chorea, it's believed because our antibody attack reside on the ganglioside of the nerve cell. Next slide. Next is the clinical manifestation. Commonly, the patient will have polyarthritis and pancreatitis. Uncommonly, they will have Syndeham Chorea, erythema marginatum, and subcutaneous nodule. The patient also might develop fever and polyarthralgia. Next, we move into the polyarthritis. It is a common presentation. It involves large joints, but rarely small or unusual joints such as vertebrae. The common joints will be ankles, knee, and wrist. At the affected joint, there will be limited motion, adequate tenderness, moderate redness, and swelling. This polyarthritis characterized by fleeting, which is lasting less than 1 week in a joint, but migrating to other joints over 1 to 2 months. Next is pancreatitis. Rheumatic fever can cause inflammation of the heart, 3 layers of the heart, which is pericarditis, myocarditis, and endocarditis. For endocarditis, it can cause vegetation and valvular dysfunction. Thus, the patient can have a murmur. And next one is myocarditis. It may lead to the heart failure and death. And pericarditis will cause the patient to have a pericardial friction rupture, pericardial effusion, and also cardiac tamponade. Next is Syndeham Chorea. Rheumatic fever, it is a late neurological sign of the rheumatic fever. It usually develops after 2 to 6 months after the streptococcal infection. Usually begin with the emotional lability and then followed by the involuntary movement of the feet, hand, and face. It is more common in female, and most observation we have the anti-neuronal antibody positive. Next. Next is erythema marginatum, which is uncommon and manifests during the early phase of the rheumatic fever. The patient will have rash on the trunks and limbs. The rash characterized by pink macule spread outwards, causing pink border with fading center. Borders may unite to give a matte light outline, as you can see in the pictures. These rash are non-pruritic. Next. Next will be subcutaneous nodule, which is rare. It is a painless pea-sized hard nodules, mainly on the external surface, as you can see in the picture. It is associated with repeated episodes and severe carditis. Next will be the complication, which is rheumatic fever will cause rheumatic heart disease, congestive heart failure, arterial arrhythmia, pulmonary edema, and also systemic emboli. Next will be the investigation. So for the rheumatic fever, we can do a full blood count, and the expected result will be anemia and leukocytosis. We also can do the acute phase reactants such as ESR and C-reactive protein. The expected result will be elevated. We also can do a throat swab, which be positive through a beta hemolytic streptococcus presence. We also can do anti-streptolysine O titer will be raised. It shows that there is a previous infection of the Streptococcus pharyngitis. And we also can do some imaging and ECG to look for any carditis feature. Echocardiogram to look for any valve involvement. And so blood culture also can be done to rule out any infective endocarditis of any bacteremia. Next. And for the diagnosis, rheumatic fever are diagnosed based on the Jones criteria, which can be divided into major criteria and 5 major criteria, and also some minor criteria, as you can see in the diagram. So the diagnoses are made when there is initial episode of acute rheumatic fever. The patient might need to have 2 major criteria or 1 major plus 2 minor criteria with evidence of preceding group A streptococcal infection. Or the diagnosis also can be made if the patient has the recurrent attack of the acute rheumatic fever. He need to have 2 major criteria or 1 major plus 2 or 3 minor criteria with the evidence of preceding group A streptococcal infection before the doctor diagnosed the child to have acute rheumatic fever. Next. Okay. Next is the simple management of the rheumatic fever. Basically, the aim of the management is to limit the cardiac damage and for symptomatic relief of the patient. First, the patient need a bed rest by restrict activity until the acute phase reactant returns to normal. And also, we also can give anti-streptococcal therapy such as IVC penicillin or oral penicillin for 10 days, or oral erythromycin for 10 days if the patient is allergic to penicillin. And also, we can also give anti-inflammatory therapy to treat the arthritis or carditis. If there is mild or no carditis, we can give oral aspirin. But if there is moderate to severe carditis, we can give oral prednisolone to 2 to 4 weeks, taper with addition of aspirin. And the next one will be anti-failure medication for supportive management. We can give diuretics, ACE inhibitor, and digoxin. Lastly, will be secondary prophylaxis of rheumatic fever, which is N-benzathine penicillin, oral penicillin, and oral erythromycin if allergic to penicillin. So, how long for the duration of the prophylaxis? It will be given till the patient reach 21 years old or 5 years after acute rheumatic fever events. Or if the child have carditis or valvular involvement, he will need to get this prophylaxis lifelong for the rest of his life. He will need to take the prophylaxis. Okay, that's all from me. And these are my references. Any question? Any questions?
Scarlet fever and Kawasaki are each other's differential diagnosis. So if you're thinking about Kawasaki, usually people ask you what's the differential, one of the differentials with each scarlet fever, because they kind of have the same fever, rash, kind of thing, isn't it? Right? Okay, no questions, and continue the next.
I have a question. What is the expected finding of liver function test in scarlet fever?
This is the presenter just now. What do you expect?
There will be high transaminase due to the inflammation.
Yeah, so usually it's either normal or your liver enzymes is slightly increased, isn't it? Right? So it can either be normal or the transaminases can be increased. Where's the presenter? Nampak tak soalan tu?
It usually, how I want to say, based on the research, it can be due to immunologic factor and also genetic factor, because some of the region in our world, a lot of the patient get the rheumatic fever due when there is a preceding of scarlet fever infection, but the other parts of the world there is no preceding of scarlet fever infection. Okay.
I think after us, if a child is diagnosed as having rheumatic fever, does it mean that it's always preceded by scarlet fever? Now, whenever you answer your OSCE, you know that whenever you write always, it's always wrong, right? It's false, right? So, as rheumatic fever is usually an immunological response triggered by a strep A infection. Now, strep A infection can be scarlet fever, can be a throat infection, upper respiratory tract infection, right? Can be a skin infection which may not have progressed to scarlet fever, right? As long as there is previous evidence of a previous beta-hemolytic strep infection, that may result in rheumatic fever, but not all rheumatic fever is preceded by scarlet fever. Some rheumatic fever might be preceded by a history of just a throat infection, sore throat, so upper respiratory tract infection, might have been preceded by a history of maybe mother will describe it as having some previous skin somewhere. Okay, not necessarily full-blown scarlet fever. Okay, kalau okay, then the next one.
Okay, hello, can everyone hear me? Hello?
Yes,
Yeah,
yes, yes.
Okay, okay. Good morning to everyone. Let's get started. I am Nia Aisha Amali, and without further ado, we will proceed by discussing our third topic of immunology, which is systemic lupus erythematosus, or well known as SLE. Okay, next. Okay, this is the outline of for SLE. We will go through the definition, epidemiology, etiology, pathogenesis, clinical features, diagnosis, investigation, management, complication, and prognosis. Okay, next. For the definition, according to Nelson Pediatric and Pediatric Protocols, SLE is defined as a chronic multi-system autoimmune vessels and tissue antibodies against self-antigens. The most significant autoantibody present in 95% SLE is anti-nuclear antibody, ANA. Okay, next for the okay, SLE occurs in both children and adults. However, it predominantly affects females during their reproductive years. Childhood SLE is defined as onset of disease before the age of 18. Childhood SLE is quite rare compared to adult. Reported prevalence of SLE in pediatric population is about 1 to 6 cases per 100,000. It is lower than that in adults, which is 20 to 70 cases per 100,000. Only 15 to 20% of all SLE patients occur before the age of 18. The onset is commonly around puberty with a median age of 10 to 12 years old at diagnosis. Majority of childhood SLE present at above 8 years old. It is rare before the age of 5. The female to male ratio of SLE in children is about 4.5 to 1. Okay, we go to the etiology. Okay, the etiology of SLE means but several factors likely influence risk and severity of disease, including genetics, hormonal, and environmental exposures. For genetic, the genetic predisposition to SLE is suggested by the association with specific genetic abnormalities, including congenital deficiencies of complement C1q, C2, and C4. In addition, certain human leukocyte antigen HLA types, including HLA-DR2 and DR3, occur with increased frequency in patients with SLE. The X chromosome also plays a role in SLE risk and prevalence. The X chromosome, which contain IRAK1, MECP2, and TLR7 genes, which has been identified as a risk for SLE in previous genetic association studies. Okay, for the second etiology is hormonal. Because SLE is more affect female, especially during their reproductive years, it is suspected that hormonal factors are important in the pathogenesis of SLE. Of individuals with SLE, 90% are female, making female sex the strongest risk factor for SLE. Estrogens are likely to play a role in SLE, and both in vitro and animal model studies suggest that estrogen exposure can promote the B-cell autoreactivity. Okay, the third one is environmental exposures. The environmental exposures that may trigger the development of SLE remain largely unknown. Some studies say that certain viral infections, including Epstein-Barr virus, may play a role in susceptible individuals, and ultraviolet light exposure is known to trigger SLE disease activity. Okay, environmental influence also may induce epigenetic modifications to DNA, which it can increase the risk of SLE and drug-induced lupus. For example, the drug is procainamide and hydralazine. Okay, for the pathogenesis. As discussed earlier, several likely etiology for SLE are genetics, hormonal, and environmental exposures. All of these etiologies may contribute to the pathogenesis of SLE. The hallmark of SLE is the generation of autoantibodies directed against the self-antigens, particularly the nucleic acids. These intracellular antigens are expressed but usually inaccessible and will confine within the cell. During the cell necrosis or apoptosis, the antigens are released. Okay, as we all know that SLE skin cells are highly susceptible to damage from UV light and resulting cell death. This will lead to release of cell contents, including nucleic antigens. The individual with SLE may have greatly increased levels of apoptosis or significantly impaired ability to clear the cell debris. This can cause prolonged exposure to nucleic antigen in the bloodstream and increase the opportunity for recognition by immune cells. This will lead to B cell stimulation and autoantibody production. So number 3, the circulating autoantibodies will form immune complex and deposit in the tissues. This can lead to local complement activation, and it can initiate the pro-inflammatory cascade and ultimately can cause tissue damage. For example, antibodies to double-stranded DNA can form immune complex. It will deposit in the glomeruli and initiate inflammation leading to glomerulonephritis. Okay, however, many individuals with SLE have circulating antibodies to double-stranded DNA but do not have nephritis. So this suggests that autoantibodies are not the only pathway leading to the end organ damage in SLE. Okay, next, we go to the clinical features of SLE. Okay, any organ system can be involved in SLE, so the potential clinical manifestations are various. As we can see in the table, there are multi-system involved. For example, in constitutional, the patient might have fever, loss of appetite, loss of weight, lethargy, or lymphadenopathy. For mucocutaneous, the patient might have malar rash, discoid rash, cutaneous vasculitis, photosensitivity, oral and nasal ulcers, alopecia, Raynaud's phenomenon, livedo reticularis. For cardiovascular system, it can be pericarditis, myocarditis, or endocarditis. For respiratory system, it can be interstitial lung disease, pleuritis, pleural effusion, pulmonary hemorrhage, pulmonary hypertension, or pulmonary embolism. Okay, next, for gastrointestinal system, it can be abdominal pain, nausea and vomiting, hepatosplenomegaly, hepatitis, pancreatitis, serositis, or diarrhea. For renal system, it can cause nephrotic syndrome, proteinuria, hematuria, hypertension, and also renal failure. For musculoskeletal system, it can cause arthralgia, arthritis, myalgia, myositis, or osteoporosis. For neuropsychiatry, it can cause either headache, migraine, mood disorder, cognitive impairment, seizures, stroke, or psychosis. And last two, which is hematological, it can cause autoimmune hemolytic anemia, leukopenia, lymphopenia, thrombocytopenia, or anemia of chronic disease. And lastly is the ocular. It can cause retinal vasculitis, scleritis, episcleritis, uveitis, and also optic neuritis. Okay, the presentation of SLE in childhood differs from that in adults. The most common presenting complaint of children with SLE include fever, fatigue, hematologic abnormalities, arthralgia, and also arthritis. Okay, next. Okay, these are the picture for the types of cutaneous lupus erythematosus. We can see the acute cutaneous lupus, it shows butterfly rash. For the subacute, we can see that there is red, raised, scaly, non-scarring rash on sun-exposed areas. And for the chronic cutaneous lupus, we can see red to purple rash with discoloration and scarring. Okay, the right side, we can see the clinical manifestation of SLE according to the system. Okay, next. Okay, this is the picture for mucocutaneous manifestation of SLE. For picture A, we can see the malar rash. Picture B, vasculitic rash on toes. Picture C, oral mucosal ulcers. And D, discoid rash in malar distribution. Discoid rash. Okay, next we go to the diagnosis. Okay, the diagnosis of SLE is based on the presence of clinical features supported by positive laboratory findings. It requires a comprehensive clinical and laboratory assessment revealing characteristics of multi-system disease and excluding other differential diagnoses, for example, infection, malignancy, and other inflammatory conditions. There are several criteria that have been established in order to diagnose SLE. I listed here are EULAR or ACR classification criteria for SLE 2019, and second one is SLEEK classification criteria. Okay, first one we look at the EULAR or ACR classification criteria for SLE 2019. Okay, this classification, it includes positive ANA at least once as obligatory entry criteria. It then followed by additive weighted criteria grouped in 7 clinical and 3 immunologic. For clinical, it has constitutional, hematologic, neuropsychiatric, mucocutaneous, serosal, musculoskeletal, and also renal. For immunology, it has antiphospholipid antibodies, complement protease, and SLE specific antibodies. Okay, these criteria weighted from 2 to 10 points. So patients who accumulate 10 or more points are classified as SLE. Okay, second one is sleep classification criteria. This classification requires fulfillment of at least 4 criteria with at least 1 clinical and immunologic criteria, or the second one, biopsy proven lupus nephritis with positive ANA or anti-double-stranded DNA antibodies. Okay, as we can see in the slide, there are 7 clinical criteria and 6 immunologic criteria. Okay, next. Okay, then we go to the investigation. For investigation, we divide into initial assessment and additional assessment. For initial, we will request for blood investigation. For example, the first one is full blood count to screen for anemia, leukopenia, thrombocytopenia. And then we can request for inflammatory markers. For example, ESR and CRP. ESR is often elevated in active disease. CRP correlates less well with disease activity. The significant elevated CRP often reflect infection. Okay, then the third one is renal profile. Renal profile is to check the kidney function. It is used to screen of kidney impairments. For example, hyperkalemia or high creatinine may suggest glomerulonephritis. And the fourth, liver function test. Liver function test may be altered in SLE patients. For example, elevated ALT may be due to liver parenchyma injury, hypoalbuminemia, usually due to nephrotic syndrome in SLE. Okay, next, urine FEME. It is to check for presence of proteinuria, hematuria, or urinary CAS, which is among the manifestation of SLE. Okay, then we can request for complement C3 and C4. C3 and C4 levels are often reduced in patients with active SLE. Okay, next we can request for coagulation profile. It may show prolonged APTT. This can suggest presence of lupus anticoagulant. Okay, next, autoantibodies test. For autoantibody, we have anti-nuclear antibody, anti-double-stranded DNA, anti-Smith, anti-Ro, anti-La, and also anti-phospholipid antibody. Okay, anti-nuclear antibody is very sensitive. It is about 95%, however, less specific. So if the patient show increase in ANA, it may be due to other autoimmune disease. For anti-double-stranded DNA and anti-Smith, it has high specificity for SLE. It is about 98%. For anti-Ro and anti-La, it may be associated with neonatal lupus, or it can also suggest diagnosis of Sjogren's syndrome. Okay, next, for additional for additional investigation, we can request for imaging. Under imaging, we have chest X-ray to screen for any cardiopulmonary abnormalities such as interstitial lung disease, pleural effusion, and so on. And next, we can have ECG and echocardiogram. As we all know that SLE patients are known to have increased risk of cardiovascular disease. So ECG and echo can be done to detect any abnormalities. For example, sinus tachycardia, ventricular conduction disturbance, pulmonary embolism, or endocarditis. Okay, next is CT scan or MRI brain. It is to detect if SLE affect the central nervous system. Okay, lastly, we have biopsy. Under biopsy, we have skin or renal biopsy. For skin, we need in order to diagnose cutaneous lupus, and for renal biopsy, it is can diagnose lupus nephritis. Okay, then we go to management. Management of the child with SLE can be challenging, and treatment must be individualized among the patient. Treatment options vary depending on organ involvement, disease activity and damage, access to medication, as well as patient and institution preference. The information that we will discuss here is a broad and general guide based on the common principles. Basically, the aim of management is the first one, rapid reduction and control of disease activity to prevent long-term organ damage. Second, maintain health and function and help patient and family to cope with disease and treatment. And the last one is to minimize side effects of the treatment. Okay, next. Okay, we go to general management first. There are several things that can be done generally in order to reduce or control disease activity. For example, first one is sun protection. For all patients, applying sunblock or sunscreen, avoid prolonged exposure of the sun or other UV light, and avoid outdoor activities that carried out under the sun, for example, sports or school assembly, may help control disease and should be reinforced at every visit with the patient. Second one is adequate nutrition, especially dietary intake, for example, calcium and vitamin D, and appropriate rest also can be included. However, we need to discourage inactivity in the patient. The third one is to treat infections. Treat any infections promptly in order to control the disease. Most of the infections can be due to bacteria or virus. Okay, last one is immunization. All routine immunization are recommended in SLE patient, especially pneumococcal and influenza. However, live vaccination are contraindicated in patient who is on immunosuppressive agents. Okay, next slide. For specific pharmacotherapy, we have first one is corticosteroids. Usually corticosteroids are required by all children even in the absence of major organ involvement. It can be given orally by prednisolone or intravenously by methylprednisolone. Corticosteroids is the mainstay or basic pharmacologic therapy in SLE, but it is associated with significant side effects. For example, disturbance, weight gain, striae, acne, hyperglycemia, hypertension, cataracts, vascular necrosis, and also osteoporosis. It is important to balance the requirement versus side effects carefully. We aim for lowest possible dose to control disease with the least side effects. Okay, the second one is immunosuppressive agents. The immunosuppressive agents are now started early soon after diagnosis. It is for rapid control of disease with improved long-term outcome and the choice of immunosuppressive agents are depending on organ system involved and the severity. For example, methotrexate, leflunomide, and azathioprine are used for arthritis and cutaneous or hematologic involvement. And second, mycophenolate mofetil, MMF, and rituximab are used for hematological manifestation. And the third one, we have cyclophosphamide. It is for most severe life-threatening SLE manifestation, but it also associated with cytopenia, significant risk of infection due to immunosuppression, hemorrhagic cystitis, premature gonadal failure, and also increased risk of future malignancy. Okay, the third one is hydroxychloroquine. Okay, this is an anti-malarial drug which is recommended for all lupus patients as it can help to reduce flares, reduce autoantibody production, and also cardioprotective. However, it also associated with some toxicities. For example, it can induce retinopathy and also ototoxicity. Okay, hence patients who are on this medication need yearly eye screening and hearing assessment. Okay, others drug we have NSAIDs. It is to treat myalgia, arthralgia, arthritis, and serositis. We also can give folic acid. For bone health, to avoid osteoporosis, we can give calcium and vitamin D. For lupus nephritis, we can give antihypertensive agents. For example, ACE inhibitor and ARB. It is helpful to reduce proteinuria. And lastly, aspirin, low dose for those with significant titers of antiphospholipid antibodies. Okay, next one is complication. Okay, for complication of SLE, it may be caused by several factors. For example, medication toxicity, macrophage activation syndrome, and also infections. For under medication toxicity, as discussed before, from hydroxychloroquine, it can cause ocular toxicity or might also cause ototoxicity. From corticosteroids, the patients may face weight gain, cataract, osteoporosis, Cushingoid phases, or avascular bone necrosis. For macrophage activation syndrome, this syndrome is a life-threatening hyperinflammatory syndrome characterized by excessive activation and proliferation of T lymphocytes and macrophage, and this will consequently cause massive production of cytokines. Therefore, the patients might have persistent high fever, pancytopenia, hepatosplenomegaly, hepatic dysfunction, coagulation abnormalities, as well as encephalopathy. And last one is infection. Infections are common in SLE and remain a source of mortality. The types of infections, for example, pneumonia, UTI, cellulitis, or as well as sepsis. Okay, next we go to the last part, which is the prognosis. The outcomes for SLE have improved significantly over past several decades. The severity of pediatric SLE is notably worse than the typical course of adult onset SLE. However, because of the advance in diagnosis and treatment of SLE, survival has improved. Currently, the 5-year survival rate SLE is approximately 95%, and 10-year survival rate remains 80 to 90%. The increased mortality rate may be caused by lower socioeconomic family, increased disease activity, and also patient with severe lupus nephritis or cerebritis. Hence, in with current advancement of diagnosis therapy as well as success of renal transplant can contribute to good prognosis. The children can live well into adulthood. Okay, I think that's all from me. Question?
I have a question. How does SLE can cause nephrotic syndrome? Can you hear me?
SLE can cause glomerulonephritis.
How does SLE can cause nephrotic syndrome?
I think, can I can I try? Although I'm
Yes,
not
you are
very
sure.
I think like SLE can
Sure.
sorry, Doctor. SLE can cause glomerulonephritis, right? So by glomerulonephritis, and then the glomerular filtration rate is not efficient, and it causes a lot of protein loss.
Glomerulonephritis and nephrotic syndrome are two separate things. Don't conflict the two. Don't conflict the two. Don't conflict the two diseases. If you're talking about hello, hi.
Yeah, doctor, I'm hearing.
Because glomerulonephritis and nephrotic syndrome are two things, so you don't conflict the two diseases. Glomerulonephritis is glomerulonephritis. Nephrotic syndrome. Nephrotic syndrome is postulated to be an immune-mediated thing, isn't it? Right? So it's not
stretch to imagine that SLE can also cause nephrotic syndrome in addition to being manifesting as lupus nephritis.
Hello?
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 Okay.
Hello?
Can you just, Hello. Hello.
Not clear, doctor.
Yes, doctor. Hello, doctor. Can you hear us?
Hi. Can anybody hear me?
Yes, doctor.
Yes, doctor
Can
can
hear
hear.
you.
We can hear.
No, nephrotic syndrome nephrotic syndrome is where you get mainly proteinuria, isn't it? Right? Now, nephrotic syndrome
Yes.
by itself is primary and primary cause or secondary cause. In children, most of the time it's minimal change. That's why they don't do. That's why they don't do biopsy unless there's an atypical cause of the disease, right? Now, secondary causes of nephrotic syndrome would be SLE. But whatever it is, it's because there's a damage to the glomerular structure resulting in proteinuria. Now, both glomerulonephritis and nephrotic syndrome, the pathogenesis is immune mediated. So it's not really a stretch to, just think of it simply as in SLE is an immune mediated problem, right? So as an immune mediated problem, it can manifest as lupus nephritis, or it can manifest as first as nephrotic syndrome. How do I say this?
Okay, doctor. Understand.
Right?
All right, can everyone hear me?
Yes.
Okay,
Yes.
I am Izatun, and today I will proceed with juvenile idiopathic arthritis, or known as JIA. So next slide. So this is the outline. Next. So by definition, JIA actually is one of the commonest traumatic disease in children, and one of the most common chronic illnesses in children. It is a heterogeneous group of chronic arthritis in childhood. However, this GIE is a diagnosis of exclusion. So meaning we cannot jump into conclusion that this is JIA, and unless it is fit into these four criteria, which are persistent joint swelling. The symptoms happen more than 6 weeks duration, and it presents before 16 years old, and there is an absence of infection or any other defined cause. Next. So GIA is, like I said, it is most common chronic rheumatologic disease of childhood, and the worldwide prevalence is 0.8 to 22.6 over 100,000 children per year. In USA, 1/3 of the children having JIA. In terms of age onset, oligoarthritis happen in the year of 2 to 4 years old. Polyarthritis the age onset peak at 2 to 4 years old, and also at 10 to 14 years old. Meanwhile, systemic JIA can happen between 1 to 5 years old. The girls are affected more commonly than boys in both oligo and polyarthritis. Meanwhile, there is no gender predominance in systemic JIA. Next. The etiology is in GIE is unclear, but there is immunogenetic susceptibility and external trigger can be factor. So the genetic factor involve MHC class 1 and 2, and also non-HLA loci. For non-genetic, it includes bacterial and viral infection, joint trauma, abnormal reproductive hormone level, and yes, next. So the pathogenesis of GIA. Generally, GIA is caused by overactivations of the immune system. So the culprit here is the T lymphocyte, which it has central role, where it releases pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin 6, IL-1A, which it also favors the activations of type 1 helper lymphocyte. and this further inflame the synovium and eventually thicken the synovium. And with times, the infiltrations of this thing will make the synovium become hypervascularized. And this is why the joint looks swollen and become inflamed. And then at the same time, numerous proteases produced by synovial cells, such as synovial cells of the arthritic joints, chondrocyte, macrophage, and polymorphonucleate cells, can cause further tissue destruction, particularly the articular cartilage, and eventually it causes destruction at the underlying bone structure. Next. So this is the picture of arthroscopic the shoulder of a child with GIA showing pannus formation and cartilage erosion. So an advanced and uncontrolled GIA will lead to pannus formation and also progressive erosion of the articular cartilage. Next. So GIA can be classified into four, which is the oligoarticular, polyarticular, systemic onset, and also spondyloarthropathies. Next. So oligoarticular by the name itself. So oligo meaning by definition, it means the presence of arthritis in less than 4 joints within 6 months of diagnosis, and it is often involves single joint. And meanwhile, polyarticular, it is the presence of arthritis in more than 5 joints within the first 6 months of diagnosis, and it can affect both upper and lower extremities. In oligoarticular, it is most common form with approximately 50% of the cases compared to polyarticular, and in both classification, there will be female gender predominance compared to male. For epidemiology, in oligoarticular, so the young children, it mainly peak at 1 to 3 years, and another peak at 8 to 12 years. Meanwhile, for polyarticular, it can affect any age. However, it can peak in early childhood between 2 to 4 years old, and also the second peak will be in adolescent year between 10 to 14 years old. There will be positive rheumatoid factor in polyarthritis, which it resembles the characteristic of rheumatoid arthritis in adults, while it is absence of rheumatoid factor in oligoarticular. In oligoarticular, the types of joint that is predominantly affected is the medium size to large joints. It is most commonly affect the lower limb joint, commonly the knee and followed by the ankle. And also it is unusual for small joints like the fingers or toes or neck and hip involvement. For polyarticular, it is mainly affected small to medium joints, especially on the hands, feet, ankles. It can also affect the wrist and knees. It can also affect the cervical spine, which involve in leading to fusion of the spine over time. There is an absence of systemic features in oligoarticular, but in polyarticular, there is systemic features where there is systemic inflammation such as malaise, low-grade fever, and growth retardation. There's no laboratory findings in oligoarticular, but in polyarticular, we can found there is an anemia of chronic disease and also elevated marker of inflammation. Next. For systemic GIA, by definition, systemic GIA does not present with onset arthritis, but rather with preceding systemic inflammation. And it is only affect a small subgroup of patients, mainly 10% of the cases. And like I said before, there's no gender predominance, female and male are bothly affected. And it affects 1 to 5 years old children. For systemic JIA, it will affect small to medium joints. So the arthritis of JIA follows the systemic inflammation by 6 weeks to 6 months, and it is polyarticulate in nature. So there are several systemic manifestations. The first one, the patient will present with fever, typically recurring, and they also the fever is also spiking in nature, where the temperature is more than 39 degrees Celsius, and it occurs once or twice daily for at least 2 weeks to months, with a rapid return to normal or subnormal temperature. Secondly, it can present with rash, typically morbilliform, which is the rash looks like measles, and it has salmon colored, and the rash can distributed over the trunk and also the proximities. And there will be the rash may be evanescent, which means it lasts for a few hours and occur at times of high and fever only. And the rash is non-pruritic, meaning it is rare for the rash to be urticaria in nature. So for the laboratory finding, there will be elevated ESR and C-reactive protein, WBC, and platelet counts. And also they will present with anemia. Next. So the last one is spondyloarthropathies, which is a group of arthritis, a family of chronic diseases of joint that may occur in adult and children. These involve the inflammation of the exoskeleton and also the sacroiliac joints, and it can also can cause enthesitis or inflammations of the tendinous insertion, where it can present with juvenile ankylosing spondylitis that affect mainly the joint, the psoriatic arthritis, and also arthritis associated with IBD. And commonly it affect male more than female, and it affect medium to large joints, including sacroiliac joint. Next. Okay, this is the important slide. Okay, this is just the summary. You can read it after this. Next. Okay. The clinical manifestations of JIA can involve articular and extra-articular. So for articular, it can cause joint swelling, joint pain. It may be present and may be absent, joint stiffness or galling after period of inactivity, joint warmth, restricted joint movement, and limping gait, especially in the morning. But it improves with time. But it may improve with time. So for extra-articular, generally, for general features, the patient present with fever, pallor, anorexia, loss of weight, and can affect the growth disturbance. For general, such as growth failure, delayed puberty. For local, it can affect the limb lag, size discrepancy, and micronactia. So micronactia is the mandibular hypoplasia, where the baby has small jaw. For the skin, it can cause subcutaneous rheumatic nodules, rash, it either systemic rash, psoriasis, vasculitis, and also nail pitting. Other involvement, it can cause hepatomegaly, splenomegaly, lymphadenopathy, especially axillary lymph nodes, serositis. Serositis, it can cause pleuritis and pericardial effusion, muscle atrophy, especially at the extensor muscle like the vastus lateralis, and it can cause avutis. Okay, avutis, especially anterior avutis, which is seen in 20% of the children in both oligo and polyarthritis. Yes, polyarthritis. Next. So since JIA is a diagnosis of acquisition, so the diagnosis of arthritis is very broad, and we need careful and thorough history, clinical manifestation, and investigation to exclude other possible causes. So for DDX, this is from the pediatric protocol, which is divided into monoarthritis and polyarthritis. So for monoarthritis, can subdivide it into acute or chronic disease. For acute, such as acute rheumatic fever, reactive arthritis, and the list goes on. For chronic, we have oligoarthritis, ERA or enthesitis-related arthritis. For polyarthritis, GIA with polyarthritis with rheumatic factor positive or negative, reactive arthritis, Lyme disease, SLE, and etc. Next. So there are several investigations that can be performed. But before that, the diagnosis of this disease is essentially based on the clinical. Meanwhile, the lab investigation are just supportive, meaning there's no lab test and combination test that can confirm that the disease is actually JIA. So first one, we can perform full blood count and full blood picture. This one can tell you that there is an anemia of chronic disease or not, and can exclude leukemia. Second is ESR and CRP. So it is the marker of inflammation, and also it helps to monitor the disease progression, monitor the disease activity. Third is ANA antibody, which this ANA antibody is risk factors for uveitis, and followed by rheumatic factor. This one is helpful to identify early onset of adult rheumatoid arthritis, and also it can help to assess the prognosis in polyarthritis and the need for more aggressive therapy if the therapy seems like unsuccessful. And then synovial fluid aspiration. This one can help to exclude suppurative arthritis, where we can see there is more neutrophils compared to lymphocyte, and other tests such as anticeptrolysine, other tests such as ASOT and complement levels, which help to exclude other causes of arthritis like rheumatic fever. And radiology, we can perform bone X-ray and MRA. We can see either the bone is normal or there is a soft tissue swelling, osteopenia, erosion fusion, subluxation, and also bone proliferation. Okay, this is the example. At the right side is the chest, is the X-ray of this. Okay, so at the right side, okay, it is ankylosis in the cervical spine at several levels due to long-standing juvenile rheumatoid arthritis. Okay, at the left side, okay, you can see there is widespread of osteopenia and also carpal crowding due to cartilage loss, and also there is an erosion that affect carpal bones and metacarpal heads in particular child with advanced juvenile rheumatoid arthritis. Next. So this is the picture of MRI. Okay, at the left you can see multiple erosions of the carpal bone. While at the right, it is after treatments of gadolinium contrast, where you can see there is uptake consistent with active synovitis. Next, so for management, so we aim to suppress the inflammation and also preserve and maximize the function. We want to prevent further deformity and also lastly to prevent blindness of the children. Okay. Next, for management, it can can divide it into two, either is pharmacological or non-pharmacological. For non-pharmacological, we have physiotherapy by avoid prolonged immobilization, strengthen the muscle, improve and maintain range of movement. In occupational therapy, splinting if required to relieve pain and preserve the joint alignment. For ophthalmology referral, all patients must have uveitis screening at initial diagnosis. Next, for psychosocial support, this is important to improve the self-esteem of the children, and also counseling and family support may be necessary. For nutritional support, we have to ensure that a healthy, well-balanced diet with special emphasis on the calcium intake. This is important to promote bone health. And next, so, okay, this is the pharmacological therapy. Okay, we can use ibuprofen, naproxen, indomethacin, diclofenac, methotrexate, and the list goes on. Okay, next. Okay, according to American College of Rheumatology (ACR), criteria for complete remission, there are several criteria that have to be fulfilled. First, there is no inflammatory joint pain, no more stiffness, no more fatigue, no synovitis, no progressions of damage, ascertained in sequential radiographic examination, and also no elevation of the ESR and CRP level. Next. So there are several complications of JIA. The first one is chronic anterior uveitis, which is common but asymptomatic. This one can lead to severe visual impairment. That's why it is needed to have regular ophthalmological screening. So next is flexion contracture of the joint. If it is left untreated, it will cause joint destruction and need for joint replacement. Next is growth failure. This may be due to generalized from anorexia, chronic disease, or taking systemic corticosteroid therapy. Apart from that, constitutional problems such as anemia of chronic disease and also delayed puberty, osteoporosis. Okay, this osteoporosis, we can reduce the risk by taking dietary supplementation such as calcium, vitamin D, and also by having regular weight-bearing exercise, and minimize the consumptions of oral corticosteroid use. Lastly is amyloidosis. However, this one is a rare complication for GIA. So next, for the prognosis. Okay, GIA has excellent prognosis. About 85% has complete remission rate. For oligoarticular, it has good prognosis. Meanwhile, for polyarticular and systemic onset, mostly have functional disability. For children with systemic onset, plus positive rheumatic factor, plus they have poor response to therapy, and also there is evidence of erosion on the X-ray. This might lead to poor prognosis. Okay, this is my reference. That's all. Thank you.
Any questions? Not.
Uh,
In GIA, yeah, sorry.
I have two questions. Firstly, you said that GIA is due to diagnosis of exclusion. Then, in the earlier slide, you give the criteria. Do we need to complete all the criteria to diagnose the disease as GIA? And then the second question is that I want to confirm something. So the main culprit in GIA is the T lymphocyte.
The lymphocyte, okay.
Hmm.
Okay, Hayati.
Yeah, you want to answer your friend?
Right, I will answer the first question. So the first question asks about the criteria. Do we need to fulfill the criteria, which is the persistent joint swelling, more than 6 weeks duration, it present before 16 years old, and absence of infection and undefined cause? Yes. Okay, yes, I think so. Because this is diagnosis of fusion, we have to look back uh, from the history, the clinical presentation, and also the investigation. Also, the investigation that we do is we want to exclude the diagnosis. And then after we fulfill this criteria of 4, yang dekat at the earlier slide, so and then we can jump into conclusion. This is JIA.
No, I think the problem comes from your slide printing there in bold that it's a diagnosis of exclusion. Yes, it's a diagnosis of exclusion, but it's diagnosis of exclusion in the sense that you must make sure that it's not anything else that's serious, because your differentials for things like persistent fever, fever of unknown origin would be things like malignancy, leukemia, isn't it? And then the other thing is that the duration is so long, it's 6 weeks duration. Your patient wouldn't present after 6 weeks, right? So usually what happens is that we present after 1 week history of intermittent fever or prolonged fever. And then took all the blood, couldn't figure out what's wrong. White cell a bit high, platelet a bit low. And then after that, the second week suddenly, and then by the second week, you start having joint pain. Might, if it's polyarticular, start off from one joint, then go off to another, oligoarticular. So within those 6 weeks, usually you would have needed to make sure that it's not any one of your differential diagnosis, and really make sure that it's not leukemia. Because also at the end of it, if one of the treatment modalities of GIA is to give steroids, if you give steroids to a kid with leukemia, what happens? Guys, any answer? You may mask the findings. Okay. So yes, all those 4 things must be done. It's persistent joint swelling, but not really persistent also, because it depends on whether it's a polyarticular thing, whether it's an oligoarticular thing. If it's polyarticular, it's the small joints, but it might not be the same joints throughout all 6 weeks. And then it's 6 weeks of duration of symptoms. Obviously, juvenile idiopathic arthritis, so must be before 16 years lah. And then you must make sure that you've done everything else and make sure that it's not caused by anything else, that they basically you cannot find the reason for it. Because if you look at the diagnosis, so all the blood investigations that you do also is not definitive, isn't it? All the blood investigations that you do, whether it's CRP, ESR, whether it's ANA, not, it's basically just supportive. You look at it as a whole, not as a singular thing. This is positive, though your child is GIA. Got it, not? Yes, no, I don't know. Guys, you guys have to like angguk kepala or something lah.
Yes, doctor.
Yes, doctor.
Okay. Second part, presenter, please answer. Lymphocytes, the one.
So for second part, which I say the T lymphocyte is the main culprit, is because this T lymphocyte, it will somehow activate, it will release pro-inflammatory cytokines, okay, such as tumor necrosis factor, interleukin 6, interleukin 1A, and also can activate other B cells, B lymphocytes, and at the same time it activates the complement system, it can cause, it can lead to immune complex formation. So by having all this, and this thing will infiltrate in the synovium. That's why it can make the synovium to be hypervascularized. Does it answer your question?
Yes.
Okay.
Why you want to say?
I have one question nak tanya. If is polyarticular GIA is same as rheumatoid arthritis or is it different?
It's different. Different. GIA is GIA, rheumatoid arthritis, rheumatoid arthritis. Rheumatoid arthritis, please go and read up. It's a different thing, okay?
Okay, hello.
Yes.
Okay, can we proceed to the last topic?
Yes.
Okay.
Yes.
Okay. Okay, so I will be ending our seminar with the last topic, which is on Inox-Schondern purpura, or shortly known as HSP. If my voice isn't clear, or it is tersekat-sekat, feel free to tegur. Okay, so what is HSP? Okay, so HSP is an acute IgA mediated disorder that is characterized by the vasculitis of the small vessels of the skin, joints, gastrointestinal, and kidneys. Now, in this disease, there is deposition of IgA immune complex in the endothelial lining of the blood vessels of the targeted organ. However, it rarely involves the lungs and CNS. The exact etiology is yet to be known. Now, HSP, it is the most common systemic vasculitis in children, and it commonly occurs in children aged 3 to 15 years old. And boys are more affected compared to the girls. And there is higher cases during the winter compared to the summer. Okay, so the exact etiology, as I said, it's unknown. However, researchers have said that this disease is multifactorial, in which the kid might be having genetic predisposition, and triggering factors such as infection or drugs are found to be linked to this disease. In about 50% of the cases of HSP, there is a preceding infection of the upper respiratory tract. Okay, so we are well aware that there is IgA circulating in the blood vessel. Now, when this IgA is exposed to antigens or drugs, it will result to production of the IgA immune complexes, and this complex will deposit in the small vessels. However, researchers have also found that aside from that, IgA in itself can aggregate together and also deposit in the endothelial lining of the small vessels. Now, this deposition will lead to influx of inflammatory mediators such as TNF-beta, IL-1, IL-6, interleukin-8. So all the white blood cells will go to the site, and this will cause inflammation. So small vessel vasculitis will happen. Now, when the IgA deposits in various organs, the children may have symptoms from various systems. Okay, so in HSP, there is a tetrad of symptoms. The first one is the purpurate rashes when the IgA deposits in the vessels of the skin. Second one would be abdominal. The second one would be arthritis because the IgA deposits in the joints. The third one would be abdominal pain. And the fourth one would be renal manifestation. So let's go to it in detail. So the most classic symptoms of HSP is the skin lesions, which are characterized to be non-blanching, palpable, purpura. Now, why is it palpable? Palpable because there is deposition and there is swelling underneath the skin caused by the deposition. And now this purpura, it is commonly found in the buttocks and also lower extremities. It initially begins as small macules that rapidly coalesce into purpura with areas of ecchymosis. Aside from that, edema can also be seen in the calves, labia, and scrotum. Okay, arthritis is a common symptom in about 80% of children with HSP. So that is like a lot. And usually it affects the knee and ankle joints. However, joints of the elbow, of the shoulder can also be affected. Aside from the pain, there can also be periarticular swelling. However, in arthritis of HSP, warmth and erythema are unusual. And because of this pain, the child will cry and they refuse to move because there's pain. Okay, in gastrointestinal features, they might have mild to moderate crampy abdominal pain. They can also have nausea and vomiting, and less commonly, bloody stool or bloody diarrhea is seen. In some small cases, this GI manifestation can precede the onset of rash. Okay, so for renal features, most cases are mild. However, some child may have cross-hematuria. Okay, so these are the investigations that we can do. However, bear in mind that no lab test is diagnostic of HSP. These tests are used to differentiate between HSP and also other differential diagnosis, and it can also differentiate between the purpura of HSP and purpura of other diseases. So let's go to the first test, which is the full blood count. Now, in a patient with either frank bleeding or occult bleeding, we can see anemia, and the patient can also have leukocytosis and platelet. The platelet in HSP, it is normal or elevated. So this is why the purpura in HSP is known as non-thrombocytopenic purpura. So the inflammation markers we can do, and we can see that there will be elevation. Next one would be urinalysis. Now, urinalysis is said to be done for all children that we suspect to be having HSP because we want to see if there is any renal involvement. Okay, so if the child has cross hematuria, we can see that there is renal involvement. However, in a child with maybe having with microscopic hematuria, we cannot see, hence why we need to do urinalysis. So in urinalysis, we can see red cell cast, presence of white blood cell, microscopic hematuria, and even proteinuria. Now, when there is abnormalities in the urinalysis, we should then proceed to doing BUN, blood urea nitrogen, and also creatinine to look at the degree of the renal impairment. Okay, now if we do IgA, serum IgA test, it will be increased in about 50% during the acute phase. In some cases, we might want to do fecal occult blood test, and there will be presence of occult blood. And in those children that present with only abdominal pain, no rash, we should consider other differential diagnosis. So for example, we can test for serum lipase to see if there is any pancreatitis. Now for imaging, we move on to imaging. Imaging, particularly the abdominal ultrasound, we do it when there is significant abdominal symptoms from the child. Okay, so for the next one is the biopsy of targeted organ. It is only done for patients with unusual presentation or for those with significant renal disease. Now, if we do either skin or renal biopsy in a patient with HSP, there will be leukocytoclastic invasion and we can see the IgA deposition. So diagnosis is made clinically. So this is the table from Nelson's Essential Pediatrics. So to diagnose HSP, it's based on the presence of 2 out of 4 criteria. The criteria being palpable purpura, abdominal pain, diagnostic biopsy, and being in a pediatric age group. However, in some sources, if you encounter them, they may say that to diagnose HSP, you can make based on the 4 criteria lah. The rash, the child have rash, and either 2 or 3 of the criteria, which is arthritis, abdominal pain, or renal involvement. So these are the differential diagnosis. So if for purpura, we can suspect other diseases such as ITP, HUS. Okay, for arthritis, you can put in SLE, GIA, or rheumatic fever. Now, if the patient presents only with abdominal pain and no rash, it is a bit difficult to diagnose it as HSP. So we need to consider other causes. So for the management, the management is to give supportive treatment, okay, to relieve the pain, the joint pain, the abdominal pain. So we can give NSAID for the arthritis. And since this disease is immune mediated, we want to give a corticosteroid to inhibit the immune system and relieve the GI symptom and also the renal disease. Okay, so for the complications, HSP, mostly it resolves completely within 3 to 4 weeks. However, the rashes can recur. So, yeah. Arthritis does not recur and it does not leave a permanent joint damage. For gastrointestinal complication, the most common one is intussusception. And in a rarer but more devastating cases, the child may be complicated with bowel obstruction or even bowel perforation. For renal complication, the child rarely will develop renal failure. So for the prognosis of HSP, it is excellent. Most children can get complete resolution without any devastating sequelae. However, for patients with a persistent marked proteinuria and elevated BUN, which shows that they have a HSP, renal disease, there is a risk for them to develop hypertension and renal insufficiency. Hence why even after the acute phase, the acute phase of this disease has passed, we still need to do urinalysis and BUN and creatinine to monitor the patient's renal progress. However, compared to HSP in adult, HSP in children, the nephritis is less prevalent, so only a small number will progress to end-stage renal failure. So this is my references. Is there any question? So I'm guessing there's no question. So thank you. That is all for our seminar.
Question very. They can become inflamed. So that's how you get intussusception, because within the blood vessels within the intestines, if there is vasculitis. So when you get intussusception, it's basically telescoping, right? So when you have a nidus there, it makes it easier to telescope. So if there's vasculitis, there's certain vessel there, there's vasculitis, so it becomes like irregular, so it's easier for it to fall onto itself. Right, same reason why they can present with stroke, hemorrhagic stroke, brain stroke or blood vessels. Same reason why they present with nephritis as well. Any questions? Don't have. Afiq, sorry, Afiq, you message me what? Next week got another class, is it?
Yes.
With me, is it?
Seminar. Ada another seminar.
Seminar apa?
Seminar infectious disease. Yes, doktor.
Seminar apa? Disease yang mana?
Infectious disease.
Yelah, infectious disease yang mana?
Banyak-banyak
nama punya ni.
Ada Denggi.
Denggi lagi?
Malaria.
Tuberculosis.
Semua orang pun dah penat, dah 2 jam duduk sini. Kan? It's what next? Selasa depan? Selasa depan ya? Pukul 2.
Sekejap doktor, saya nak refer balik.
Tak apa. Bila dah refer nanti WhatsApp balik kat saya. Yang datang lambat tadi, I got a few videos, resources pasal cardiovascular system examination. I dah WhatsAppkan link tu pada Malina kan? Amalin. Nanti siapa kat belakang tu adik? Aziz adik kat belakang. Okay. Bye-bye.
Okay.
Thank you, doctor.
Bye-bye, doctor. Thank you.
Bye-bye.
Thank you, doktor. Thank you, doktor.